there are many concerns while doing a case of CRS HIPEC. And it's a very challenging task for every anesthesiologist to meet this goal. I'll just brief in certain points about CRS HIPEC. Cytoreductive surgery with hyperthermic intraperitoneal chemotherapy is an acceptable therapeutic modality for peritoneal surface malignancy. This peritoneal surface malignancy, either they are primary of origin, that is pseudomyxoma peritonei, or they might be secondary because of malignancies from ovarian cancer, colorectal cancer, or CA stomach. Most common is the ovarian cancer, which metastasis to the peritoneal surface about 82%. Before the introduction of CRS HIPEC procedure, this peritoneal malignancies were considered as incurable, and patient has an only option of palliative care. But after introduction of CRS HIPECs, which is a complex procedure, they have given a new hope and better survival and better quality of life to these patients. As the name suggests, it is a complex procedure and hence is the complex task of perioperative concern. Thus, a multidisciplinary team approach is extremely essential to manage such type of patient. In World Federation Society of Onco-Anesthesia, the studies have given that pseudomyxoma peritonei, the 5-year and 10-year overall survival rate can reach up to 90% and 80% respectively. Dr. Paul Sugar-Baker shows that the surgical removal of all the visible tumor from the peritoneal mesothelioma, if it is combined with a loco-regional heated chemotherapeutic drug, improves the quality of life and the survival of patient. Hence, CRS HIPEC is indicated in pseudomyxoma peritonei, colorectal cancers, ovarian cancers, gastric cancers with isolated peritoneal metastasis. Let me brief you about the surgical technique. In the surgical technique, there are 3 major steps. The first is exploration, second is cytoreductive surgery, and third is chemoperfusion. What happens in the explorative procedure? The surgeon performs a diagnostic lab or a mini laparotomy so as to calculate the PCI index. What is PCI index? It is the precancerous index where you can do the scoring of the nodes involved or the disease spread. If it is less than 20, then patient will be benefited for HIPEC CRS procedure. If the score goes more than 20, then the patient will not have that much benefit, and the project this patient for such a major procedure will not have a better outcome. So exploratory laparotomy or diagnostic lab is done. Then is cytoreductive surgery, where all the visible tumor is debulking occurs and major of the tumor is removed, and less than 0.5 mm tumor, if it is remain, then the chemoperfusion or the third stage is run, that is abdominal cavity is rinsed with a heated chemotherapeutic solution. There are 2 techniques of HIPEC. One is open abdominal technique and the another is closed abdominal technique. After doing cytoreductive surgery and achieving a CC score of 0, that is cancer clearance score of 0, the infusate of heated chemotherapeutic agent then infused into the intraperitoneal surface. It is allowed to act locally to the remaining tumor. Even distribution of temperature and chemotherapeutic agent occurs in open abdominal technique. But the disadvantage is that heated chemotherapy may lead to aerosolization and causes inhalation of exposure to the operating personnel. In closed abdominal technique, once the CRS is done, the catheter and the temperature probe, they are kept inside the abdomen. Then the abdomen is closed and the intra-abdominal pressure rises. As a result of this, it creates a lot of load on the respiratory system. The diaphragm gets shifted. There is a decrease in the FRC, and you need to manage the ventilation in a different strategy. The biggest advantage of closed abdominal technique is that there is a deeper penetration of chemotherapeutic agent, and thus the clearance of tumor cells is adequate. The disadvantage of this technique is that uneven distribution of hyperthermic chemotherapy occurs. The drug may get pooled and accumulate in the dependent part of the abdomen, which may lead to the postoperative ileus, bowel perforation, and fistula. This is an overall circuit of HIPEC. There is an infuser or the machine of HIPEC where you can connect the infusate and the chemotherapeutic agent can be mixed. This is then goes into the inlet of the tubing, where it passes through the thermostat and get heated to around 40 to 41 degree. Then this heated solution of chemotherapeutic drug is passed into the abdomen, either by the closed or open abdominal technique. It is allowed to act there for 30 to 90 minutes. And then this all chemotherapeutic agents and the solutions is then drained through the outlet. And whatever the infusate amount, say around 1.5 to 2 liter is been used, the approximately that much amount should be taken drained back with some tissue loss. So the overall complexity of this procedure is anesthesia induction. the cytoreductive phase, which is the major phase, and it may last from 3 hours to 6 hours or sometimes to 8 hours, depending upon the tumor load and tumor burden of the patient and the time taken by the surgeon to reduce all this tumor burden. There is a major anesthesia problems occurs in this cytoreductive phase, major fluid shift, blood loss, and many more problems. Then once your cytoreductive surgery has been done, then the patient is subjected to HIPEC. That is the another 90-minute phase, 30 to 90 minutes. If at all, if it is a colorectal cancer or gastric cancers and anastomosis or reconstruction is required, then another 1.5 or couple of hours is added to your surgery. Patient should be taken an ultimate post-operative care. So this is the complex course of a complete CRS HIPEC procedure. Hence, perioperative challenges while dealing a patient with a CRS HIPEC as massive fluid shift, massive blood loss, which cannot be predicted. There is a variation in temperature, either hypothermia, then hyperthermia. There is a extremes of hemodynamic changes, renal insult because of the chemotherapeutic agent which you are using. They might be nephrotoxic. There occurs a coagulopathy because again of fluid shift, temperature changes, and episodes of venous thromboembolisms are very high. So we have to have a very strategic planning while giving anesthesia to CRS HIPEC procedure. Stage-wise evaluation and consideration of patient will lead to the success of the surgery. In the preoperative period, a detailed pre-anesthesia evaluation is done. Comorbidities are supposed to be ruled out. Apart from all our investigations and routine and detailed preoperative checkup, patient should be counseled for the prolonged hospital stay, expected outcome, cost involved, risk involved, and the quality of life. Prehabilitation is again a very important part in CRS HIPEC procedure. While considering this patient or subjecting this patient to the procedure, patient's nutritional status assessment and albumin level is very essential. There are predictors of malnutrition like weight loss of more than 5% in past 3 months, reduced intake or body mass index of less than 18.5. So these patients will have a longer hospital stay and the incidence of complication in the post-operative period will be high. So the patient's nutritional status should be built up. The albumin should be built up before you subject this patient to the procedure. There is a compromised respiratory condition because of ascites, abdominal distension, the respiratory system get compromised. Hence, incentive spirometry plays an important role to build up the respiratory parameters. Venous thromboembolic prophylaxis need to be given as per your hospital protocol. Respiratory system, as I have told you, and because of ascites and pleural effusion, there is a diaphragmatic splinting occurs with the basal atelectasis. There occurs a hypoxia in a pre-operative period. Hence, chest X-ray, CT scan, ABG analysis, and pulmonary function test should be at your hand. In cardiovascular system, because of the CRS and HIPEC procedure, there are two extremes of events are happening. During CRS, because of peritonectomy, resection of the raw area and ascitic drainage, there is extreme of blood loss and very minute oozing of the serous fluid occurs continuously. So this will cause a profuse hypotension and decrease in the cardiac output. While during HIPEC procedure, there occurs a peripheral vasodilatation, decrease in peripheral vascular resistance, and decrease in mean arterial pressure, leading to an hyperdynamic circulation, and end result will be like tachycardia, raised CVP, and increase in the cardiac index. Intraoperatively, there are again a few consensus like during induction, one must consider rapid sequence induction because of grossly distended abdomen and ascites. The functional residual capacity of lungs being reduced. Patients are prone for desaturation. So your induction agent should be selected wisely and aspiration prophylaxis need to be given. During HIPEC procedure, there occurs a coagulation abnormality in the perioperative period. The chemotherapy, which is run, the nutritional deficiencies, the hypoalbuminia because of ascitic fluid and drainage. Long duration of surgeries in female genders, old age surgeries, old age patients, malignancies predisposing these patients to the risk of thromboembolisms and hence leading to deranged PT and INR. So if your institute provides, you can do thromboelastography in hand and you can have the coagulation profile in hand. Invasive monitoring is required, that is central venous CVP line or the arterial line. For CVP line may not give the adequate volume status or volume responsiveness, but the vasopressors can be given through the central line to maintain the blood pressure. Arterial line bit-to-bit monitoring is must and which is a guide for ionotrope to be used. Perioperative thermoregulation is very important. The two probes are essential. One is the esophageal temperature probe, which can monitor the core temperature of the patient, and another is the abdominal cavity probes where the thermostats are used in the inlet and the outlet of HIPEC machine. During CRS, there occurs hypothermia because of extensive surgical resection and exposure to excessive fluid loss and prolonged duration of surgery. This can be prevented by forced air warming blankets, warm IV fluids, increase an ambient OT temperature. And during HIPEC, there occurs an hyperthermia because the heated chemotherapeutic agent is poured into the abdominal cavity. There occurs an hypermetabolic phase, hyperdynamic circulation, and profuse peripheral vasodilatation. This can be prevented by underwater mattress, cold IV fluids, and IV packs. The ideal chemotherapeutic agent which is used in the HIPEC should have an should be hydrophilic, have high molecular weight, and slow peritoneal clearance. Patient's height, weight, and body surface area should be documented so as to have a calculated dose of chemotherapy. And dose modification should be done as per the toxicity of the chemotherapeutic agent. These are the list of chemotherapeutic agents which can be used intraperitoneally, and most of them are nephrotoxic and myelotoxic. The fluid management is again a very crucial in CRS HIPEC. During CRS, the intraoperative fluid loss may be as high as 8 to 12 ml per kg, and there is a significant blood loss depending upon the extent of resection. And there should be a liberal fluid to be given to the patient so as to maintain the hemodynamic. During HIPEC, the saline-enriched chemotherapeutic drug may increase the intra-abdominal pressure, resulting in decrease in venous return and decrease in cardiac output. Thus, crystalloids and colloids need to be balanced so as to maintain the perfusion pressure and urine output without causing any fluid overload. Patients with poor cardiac reserve or any other systemic comorbidity will not tolerate this much amount of volume shift or fluid shift and hence require vasopressors and inotropes. Blood loss in CRS reported as high as 9 liters in some of the studies. The fluid replacement strategy, as I have told, it should be liberal, either restrictive or goal-directed. Throughout the procedure, the end organ perfusion can be titrated with the simple urine output monitoring. During CRS, urine output should be around 0.5 ml per kg per hour. During HIPEC, it should be 2 to 4 ml per kg per hour. And post-HIPEC, it should be around 1 to 2 ml per kg per hour. Because of the massive fluid shift and blood losses, there occurs electrolyte disturbances like calcium, potassium, magnesium, which should be replaced at times. There is a continuous oozing of the serous fluid, even, and the collection of this massive ascitic drain, which lead to protein loss of around 700 grams. And hence, post-operatively, you need to supplement albumin to the patient. One must monitor throughout the post-operative period for hemodynamics. There are chances of thrombocytopenia, which occurs, electrolyte imbalance because significant fluid loss. The multimodal analgesia must be tried so as to have the patient pain-free in the post-operative period and early mobilization. Then stress ulcer prophylaxis need to be given. Feeding, nutrition, respiratory support, and infection, everything counts in the post-operative period. Hence, I conclude that the CRS HIPEC procedure the successful outcome requires a team approach and continuity of care with a vigilant interaction of multidisciplinary team. An extensive prehabilitation and optimization of the patient preoperatively and a vigilant monitoring intraoperative helps for a better recovery and a discharge. Last 20 days back, we have done a case of CRS HIPEC at Krupamai Hospital. That was the first case which was done at our institute. Patient was 70 years old female, diagnosed case of CA ovary with pseudomyxoma peritoni. 6 months back, patient was diagnosed. Patient was having grade 1 dyspnea and distended abdomen. Patient was non-hypertensive and non-diabetic with no other comorbidity. Exercise tolerance of this patient was moderate with a MET score of around 1 to 4. Patient was planned for CRS HIPEC. Now, patient's height was 157 centimeter with a weight of 60 kg. GC was fair enough with tachycardia, so with room air saturation of 95%. As you can see, there was grossly distended abdomen because of ascites. Her air entry was reduced at the bases. Airway was good. Lab investigations were pretty fair with INR of 1.2 and albumin was 4.2. CT scan shows the span-omental caking followed by visceral scalpelling and a huge ascites. Looking at the CT scan, one will be afraid and definitely plan for rapid sequence induction. This patient was advised for incentive spirometry, nebulization, adequate blood was kept ready, post-op ICU and ventilator support was advised. Everything was explained to the patient as well as to the relative in detail. High-risk written and informed consent was taken and even consent for photographs was taken. Anesthesia was planned and general anesthesia with central line and arterial line. Patient was pre-oxygenated in a propped up position Rapid sequence induction was planned. Glycopyrrolate 0.1 mg and antiemetic was given, fentanyl of 100 mics. Induction agent we chose was etomidate 20 milligram. Apnea ventilation was followed, and under scoline we induced the patient with the ET tube of 6.5. Patient was monitored with intraoperatively maintained with oxygen, CO, and long-acting muscle relaxant. So this was a huge laparotomy incision right from epigastric region up to the pubic symphysis. And after separating the peritoneum from on the lateral margins and above and below margins, you can see the ascitic collections and was so huge. Intraop gold standard monitoring was done with CVP, Artline, and NIBP, pulse ox, and temperature. Our goal-directed fluid was given an intraoperative during the CRS procedure. There was a considerable blood loss, specimen loss, and third space loss. So we targeted the CVP of around 8 to 10 centimeters. And CRS lasted for 3 hours, in which 4.5 liters of crystalloids was given. Towards the end of CRS, as first time patient's blood pressure dropped to 89/62, where we started with the vasopressors. And beforehand, we had 2 on the PCVs and colloid given to the patient. Once the CC score of 0 was there, then we proceed for HIPEC. This is a bookish picture where it shows, give the idea about pelvic peritonectomy in an en bloc removal for downstaging of peritoneal metastasis. And once you remove the complete peritoneum, it looks like a bat wing along with the specimen. And this was our picture in our case, where the peritoneum was removed by the surgeon, and this was the specimen collected, and this was the ascitic fluid which was collected. It was around 5 liters. So intraoperatively, patient received under pause 1 gram calcium glucomate 10 ml, magnesium supplementation was given, adequate urine output was maintained, BSL monitoring was done 4 hours. Then once the CRS was done, ABG was sent so as to plan for HIPEC procedure, which was pretty okay, except potassium correction was required. Additional potassium correction was required. During HIPEC procedure, heated cisplatin was used in this patient. Temperature was set around 43 degree. Simultaneous ice cold IV fluid, normal saline was started. This was a very important step as they prepared the machine and preloading of the tubings and all. Simultaneously, we started with the cold IV fluid so as to maintain the temperature of the patient. The HIPEC procedure lasted in this patient for 90 minutes, and we planned for open method. Maximum patient temperature rise was around 36.6 degree. Even we intermittently palpate the patient so as to check the warmth. Infuset was used around 2 liters, and drain was on the outlet drain was around 1.8 liter. So as you can see, this is HIPEC machine where the chemotherapeutic agents has been run. There are the 2 infuset of 1 liter normal saline, in which the first normal saline is used to prime all the inlet and outlet and tubings, and then in the second, the chemotherapeutic agent is added. Then we start and running this HIPEC. Here you can see, I don't know whether you can appreciate, in the center gives the time set, that is 90 minutes, 60 minutes or whatever, and the time remaining for HIPEC to run. This is the inlet temperature, and this one is the outlet temperature. So these tubing, they runs through the thermostats, and chemotherapeutic agent is for intraperitoneally, and it is allowed to remain open for 90 minutes. Abdomen was closed with 4 drains. Patient was monitored until stable hemodynamic and normothermia was achieved. With all good hemodynamics and lung recruitment, patient was reversed with Sugamadex 200 mg, and patient extubated on table at the end of 7 hours of this complex procedure with good urine output and low inotropic support. Multimodal analgesia was given. Actually, this was a video where a patient was seen in the postoperative period talking with us, very comfortable, and there was no pain. Immediately next day on the postoperative period, patient had hypokalemia with a potassium of around 2.5. Correction was given simultaneously. Albumin supplementation was required on day 2. There was no neutropenia. Patient was pouring urine output approximately 150 to 200 ml every 15 minutes. So IV fluid was replaced liberally, and CVP was maintained around 8 to 10 centimeter. Spirometry was given. DVT prophylaxis was given. On day 3, patient's the art line was removed. On day 5, central line was removed. On day 7, patient was discharged. Actually, this was a video which showed the patient did spirometry immediately next postoperative day. Day 18, patient came in the OPD for follow-up. So success of our first CRS HIPEC is because of the multidisciplinary team approach. There was proper selection of the patient, which gives us a win-win situation. Strategy planning of preoperative, intraoperative, and postoperative resulted in a good result and success of this patient. Thank you, everyone.